I must say that being able to speak to the subject is something that is quite important for me. Certainly, I do a lot of work in the field of healthcare provision to trans and gender diverse people, and indeed to other minority groups and people under the LGBTQIA+ umbrella. And one of the pet peeves that I have around that is that for so long, so much of the narrative around providing care to marginalized groups, and indeed to trans people in particular, has centered around the concept of the HIV/AIDS pandemic, and indeed this idea around key populations. And I think it's a difficult and a sensitive subject to engage with. And of course, we do know that living here in South Africa, we face tremendous disease burden from HIV. We are one of the most affected areas in the entire world. And we do know that this virus and this illness can affect anyone, but it does have a predilection for those who are the most marginalized. And often this is a response to societal conditions that force people in those marginalized groups and people who do have those identities to engage in behaviors that are generally more risky. Society does take away their agency and their right to autonomy. Sometimes we know that members of our community can be assaulted or abused without consent and exposed in that way. We know that sometimes we aren't able to find secure employment, and we turn to avenues and pursuits that do carry a higher risk of HIV infection. And I speak with specific reference to the population of sex workers, and especially in South Africa, where we still are engaged very actively in a fight for decriminalization. And hopefully this is something that we will see in the near future rather than in the distant future. But until such time as decriminalization is a reality, people who are engaged in sex work do not have access to the kind of protections and human rights that the rest of the population does. So, it is this culmination of social factors that leads to this disproportionate burden of HIV infection that is felt by the trans community. And, of course, we know that HIV is one of those conditions that triggers a global response. There's a lot of funding made available throughout the world in order to stem the tide of the HIV pandemic, in order to get people onto ART, in order to roll out interventions like PrEP. But the flip side of that is that it doesn't always bring us to address either the social conditions that drive the spread of the viral infection and affects the population that we're dealing with. And secondly, in that, it leads us to neglect so many of the other healthcare needs. And I think what makes this discussion such an interesting one for me today is that we have this specific focus on integrative healthcare, holistic well-being and wellness. And in the medical establishment, which I am by training, I am a doctor. In terms of my career, I'm both a clinician and an activist. But I'm often at loggerheads with many other people in the medical profession, because so much of what we do as doctors is centered around a model of disease and treatment. It's a model of pathologization. And certainly we know when we speak as a group of trans people, we know that the discourse around pathologization is an exceedingly difficult one. And we know that there's nothing inherently pathological about being trans or expressing oneself in a way that is gender diverse, whatever it might be. But so often there are groups who are reliant on access to care, and that access to care can sometimes be compromised under the guise of depathologization. And this is because, again, as a society, we just haven't progressed to the point where we're encouraging people to live openly and truthfully. We deny people access to treatments or interventions unless we see something is wrong with them. And it does complicate this narrative. And, I think the discussion on that is a much longer and a much deeper one than we have time for today. but it is a factor that needs to be taken into consideration when we look through this lens of HIV at what is happening to our community, and we ask ourselves the question of how do we do better. And I think one of the biggest caveats and pitfalls that we really need to try and tackle, and I have alluded to this already, but it's this idea that all that is really involved in providing adequate care or healthcare or services to people in the trans community is to address HIV, and to do that to the exclusion of other aspects of care and holistic well-being. And when I speak about that, certainly I am referring to gender-affirming care, hormonal therapy, surgical intervention for those people who desire such. But I'm also talking about psychological, emotional, mental, and social well-being. I think that in a large part, we are still living in a society that is rooted in stigma. And amongst the many things that I do often educate and teach medical students, and one of the subjects that I talk about is HIV and the effect of this virus on the human condition. One of the lecture series that I deliver to students at UCT is titled HIV and Me, and the challenge there is really to try and get medical students, young medical students, to identify with some of the challenges that HIV places, not just in a clinical or pathological or virological sense, but in a very human sense. And, if we look back at the history of this infection, it really came to light in society at large in the early 1980s. And I don't know how many people in attendance know this, but HIV was originally known as GRID, G-R-I-D, and that stood for gay-related immune deficiency. And when it first came to light, it was an infection that was predominantly seen in cisgender gay men. And of course, as time has gone by, we've learned very much that HIV will affect and infect anyone that it has the opportunity to do so. But at the time, the civil rights movement was still very much in its infancy, indeed in the US, where much of this research and learning was taking place, but of course around the world. And the stigma of HIV and the stigma of being identified as queer or as gay or as trans are very much inextricably linked. And, we see this play out throughout history. One of the most telling examples of this is how in recent years, and fortunately this is improving now, at least to some degree, but in recent years and in the decade that's preceded us, we speak a lot about key populations. And one of so for anyone in attendance who doesn't know exactly what a key population is, these are groups of people who have been determined to be more vulnerable and more susceptible to becoming infected with HIV and to suffering significant disease from it. And the list of groups considered to be key populations has expanded over time. But at one point, we spoke at length about MSM, standing for men who have sex with men, and lumped under this category were transgender women. And of course, this is tremendously problematic because it erases and invalidates the identity of a trans woman as a woman. It is predicated on biological sex, which, as we know, is a scientifically flawed concept. To think that a transgender woman is biologically male is wrong on so many levels, but it packed trans women into this box of MSM, men who have sex with men. And so many trans people were forced to access care and services from these MSM facilities because that was all that was available for them. It did go further, and at one point we spoke about WSW and women who have sex with women, and this would have this sort of very fundamental or basic rudimentary definition people would have tried to shoehorn trans masculine folk into. We never really took account for transgender people who have sexual preferences or sexual orientations that are different, that are not straight. We never accounted for trans women who identify as lesbian or pansexual. we never accounted at all for non-binary folk. And this narrative has moved forward in some ways, but it still lags behind. So, now when we speak about key populations, we do include groups like prisoners, we include groups like sex workers, we include transgender women specifically under that label. But again, we're not reaching out and speaking about non-binary folk. We're not speaking necessarily about transmasculine folk. And we are still assigning significance to these population groups in a clinical sense by virtue of the fact that they are seen as vulnerable to infection with HIV. And far too often, the funding and the services that are rolled out under this banner will allow us to do counseling and testing, will allow us to do antiretroviral treatment, will allow us to do PrEP, but will not make any provision for gender-affirming care, for hormone therapy, for primary healthcare services, treatment of diabetes or hypertension or any other chronic condition, which we know that trans people are subject to falling ill just like any cisgender person is. Excuse me. And we also know that it's very difficult for them to access healthcare services because so often they make themselves vulnerable in doing so. They have to out themselves, or they have to risk being called up in front of a waiting room full of people under a dead name because their ID documents haven't been updated or something like that. So we've never made allowance for that. We've never said we need to look at the psychological well-being. We need to make sure that this person has support. We need to look at this person in a holistic contextual sense and see what's going on with their living conditions, with friends or family, or with employment, or with anything else. And to come back to the point that I made when I opened up this discussion is to say that it is these social factors, it is people being thrown out of their homes, it is people being abused or bullied at school, it is people being unable to find or hold down employment because they are trans and because of the stigma and the prejudice associated with that, that results in all of the other factors that put people at risk of HIV infection, and if they are infected, of having poor control of that infection and ultimately suffering physical and clinical consequences thereof. And the reason I think it's important to see it through this lens is because in a lot of ways, I feel as a clinician and as an activist that our response to HIV almost has us chasing our own tail, because the antiretrovirals and the PrEP and whatever else we talk about, these are all very, very valuable interventions, but ultimately we are not addressing the root cause. We are trying to suppress viral loads, but we're not trying to address the social inequity that really allows this condition or this infection to flourish. And I think we have to tread especially carefully in this area because we don't want people to lose out on access to care. We don't necessarily want, we can't afford to lose funding for the provision of these medications or for the provision of testing. But at the same time, we also have to make a case for more resources to be allocated to addressing the underlying problems in order to try and mitigate this growing pandemic in a way that is sustainable and in a way that looks after people in a much more holistic manner that will allow people to contribute to society, to live their best lives, to seek fulfillment, to raise and support their own families without the pressures and the prejudice that they are facing. So, and I realize that time is short and there's a bit of a tight program today. So I'm going to try to wrap this discussion up a little bit. Obviously I can go into far more technical clinical details, but I do want to make sure that we keep this discussion accessible to the majority of the participants who have signed on to speak with us today. And I hope that we'll be able to unpack some of this in the discussion that follows. But definitely, I think that we are at a turning point now in society as a whole, and especially in South Africa, where we need to start thinking of very constructive ways to start amplifying, and this ties into the theme of the discussion series, to start amplifying the correct voices And instead of allowing this cycle where we look through the mainstream societal lens at the burden of HIV infection, we say this poses a problem to the straight people and the cis people and the privileged people and the educated people. And this is why we're going to do something about it. This is why we're going to allocate all kinds of international funding to combat this, because it poses a risk to the rest of society. We really need to move that forward to where we say these are all diverse elements of our society, and it's their voices that need to be heard, and it's their experiences that need to be heard. We cannot frame HIV infection and the effects that it has through the words or the ideas or the perspective of someone who is not part of this community and who doesn't have the lived experience to back it up. Any kind of interventions that we make do need to be holistic. We can't just provide antiretroviral treatment. We need to make access to gender affirming care available. We need to make easier access to legal recognition available. We need to push for decriminalization. These are all part of the same agenda, and we need to dismantle this idea that we can live and work in silos, because if we do, we are going to be chasing our own tail. We are going to be stemming the tide and trying to prevent the boat from sinking, but we haven't done anything that will actually address the overarching storm. And I think for me, that's the most important next step that needs to come out of this. I would like to thank everyone for your time and your consideration this afternoon, and I'll hand back the reins to Anil.
Thanks so much, Anastasia. That was a really insightful presentation you've given us. I'm now going to hand over to Leanne for her presentation. Thanks, Leanne.
Good afternoon, everyone. Can you hear me?
We can hear you loud and clear. Thanks so much, Leanne.
Oh, lovely. So, you know, my network connection isn't always that great, and so it's important for me to make sure that folks can hear me. I'm happy to see some familiar faces, and so I feel less technophobic because I see Whitney is here also, and I'm happy to be part of this very important conversation around HIV. And so I want to thank Dr. Stacy, who spoke just before me, about integrated care. And I almost feel like, I'm going to be the devil's advocate when we look through this lens of HIV. I mean, transgender women, undoubtedly account for the highest HIV prevalence around the globe. This was far. Hello.
Hi, Leanne. I think we lost you there.
Yes, that's, the gods of technology hate me.
I think it's also one of the burdens that you face of being on the periphery, where we are in the big urban centers. We have preferential access to technology and network. When we're bringing people
Can you
in to
still
speak
hear
from,
me?
other provinces, this is what we face. So everyone is bearing with you. Don't worry. We're here to stay and listen to you and get the technical problems right. Thanks so much, Leanne.
My apologies again about that. Just to re-emphasize that, the conversation on HIV among trans people, particularly in East and Southern Africa, is a very contentious conversation. And I think there's a long history there of it being contentious. And Dr. Stacey talked about that historical context of, trans people being subsumed within the category of men having sex with men and sex worker responses. And I think, those were useful. Don't get me wrong. It's been useful to have our voices raised in those spaces, but it was not enough to highlight the nuances and the need for a gender responsive, HIV response for the transgender community. And so, I want to highlight that there is that particular context, which has been bad, but in some ways, some days I still consider that to have been a necessary evil insofar as data is concerned. I also want to put a disclaimer that, I can't go into much of the detail due to time limit, but I'm very happy to respond in the question and answer section. And so just in the South African context, with sustained advocacy, we landed in the 2012 National Strategic Plan, and a lot of us said, yay, but we made those comments without fully realizing that being mentioned in the Strat Plan was no commitment to addressing the issues that we face as trans people. And so the Strat Plan, after that, we were officially brought into the consultation process where, we could state what we wanted as a community, but not in any way was that guarantee that it is what we were going to get. So it was also around this time that a lot of us started realizing that offering trans healthcare divorced from HIV services is really, to the detriment of the people, because it launched us into this realization that kind of like, what do I take care of? Do I look at my trans health first? Do I look at my HIV first? And this became a very real concern for folks. It was also around this time that, scholars like Jay Savalius from UCSF shifted our attention to the gender affirmation framework. And this kind of like coincided with the first Trans Health Conference, which was held in Woodstock in 2011. So in essence, the gender affirmation framework posits that that our need for gender affirmation may fling us into dangerous practices, particularly in the context of HIV. And the classical example made here is like, when clients affirm our feminine gender identities, we are more likely to be engaging in sex without taking the necessary risk precautions. So building on this work, colleagues at the Center of Excellence for Trans Health at UCSF started publishing work that suggests that we offer a healthcare services that is gender affirming, gender responsive, and that, that we had better success in retaining folks in HIV care when we offered both gender affirming care alongside gender affirming gender transition care. So I mean, for those of you who are interested, can read more on the literature, and it was called the Special Projects of National Significance for Transgender Women of Color in the US. Just some food for thought. All of what I mentioned was good for the United States, and that model works for them. But what does this mean for Africa? First, we have to realize that our battles are many as transgender folks in Africa. So we have to prioritize what is needed in order to advance our agenda. And that might look different per region, per country, per district, etc., etc. The other point that I want to make is that we live multidimensional lives. And in the various dimensions of our lives, we can, further reinforce stigma. For example, the stigma of being Black, the stigma of being poor, being HIV positive, i.e. the conversation on intersectionality. Sometimes it's incredibly overwhelming to just talk about HIV, but please realize that it serves as an entry to a bigger conversation. The thing about the HIV discourse is that it's reached fatigue for a lot of us, but we must realize the value of using HIV as an entry point to other conversations, such as quality and appropriate transition healthcare. When we worked, for example, on the LGBTI plan, the HIV plan, SENEC undertook a costing related, a costing of gender-related care as part of a comprehensive HIV response to HIV in the transgender community. So with that said, I would have never imagined that transgender-related care would be addressed in the context of HIV. And even though surgery was, it fell out as one of the elements of care in the final part of the plan, we did manage to negotiate for the provision of hormones as part of the HIV response. It's not much, I acknowledge that, but it's more than we had 10 years ago. And that's why I choose to remain positive and push forward the gender, particular agenda of intersectionality. If the HIV discourse doesn't, take count of social determinants of health for transgender people in the region, then it's of no use to talk about it, because our various social, cultural, and political environments is what is further reinforcing our vulnerabilities and our very disparate healthcare access. I just want to put the disclaimer that I referred to a lot of US literature and South African implementation science, but I believe these findings have been useful in pushing the trans health agenda for our government, with our government, and it could be useful in regional conversations too. Thank you again for listening, and I'm very happy to take questions.
Thanks so much, Leanne. I think we lost you right at the end there, but I'm going to move into the discussion now. And I hope any points you still need to make will be picked up with the questions in the discussion. What I'm going to do is I'm going to open it up to the participants. For anyone, if you have a question or a comment to make, please use the raise hands function and raise your hand, and we will take your questions. If you have connectivity problems and you can't easily raise your hand and ask questions using a microphone, you are very welcome to type in your questions on the chat group, and I will then read them out and we can deal with those questions and comments on the chat group. So either way, whatever people refer, please type in your questions or raise your hand and ask your questions, and we're now going to open it up for discussion. Thank you. Thanks, Kanyisile.
Hi, Anil. Thank you for the opportunity. I just want to ask a question relating to Leanne's presentation. So I believe Leanne was talking about how HIV care is divorced from gender-affirming healthcare, and which we know that this is something that is an issue, especially for the trans community who's incarcerated. And so I want to know if we are doing enough as civil society to push for gender-affirming healthcare, which equals gender affirmation relating to incarcerated trans persons. Because the Department of Corrections and the Department of Health still pushes the narrative of gender-affirming healthcare being cosmetic. Ultimately means that they are divorcing HIV care from gender affirming healthcare. So what are we doing as civil society? Are we putting that on our agenda? Because I work with trans persons inside the Department of Corrections or who's incarcerated. And the fight continues for them to be affirmed. And the Jade September case came in because she didn't have access to gender affirming healthcare inside the facility, and she didn't affirm herself before going into the facility. So we're still fighting that battle. And so I want to know if we are doing enough and if this is a priority for civil society to look at so that they can have access to gender affirming care inside a prison facility. And that ultimately then means that they are holistically cared for, not just looking at the HIV condition perhaps, but also looking at the gender dysphoria.
Thanks so much, Kanyisile. I think if we can ask Leanne, and then also I see that Anastasia is back, if we could ask them to give a response to that.
Fantastic. Thanks, Kanye. Thank you so much. Love. Thank you for the question. So yeah, I mean, if you look at it very much on gender affirmation and HIV, I think it also speaks to what are the social determinants, because I can offer you hormones in my clinic and I can offer you ARVs and I can offer you surgery, but what is it in your community that would deter you from coming to my facility? Like, where do I meet you, right? You aren't just looking at this relationship between HIV and I mean, I'm a very big proponent of integrative care, but I'm also really trying to integrate, like, what is it in the social determinants? For example, I'm looking at a study now that's looking at why are we failing to retain transgender women in HIV care. And one particular thing that is starting to surface, and I mean, when I started the study, I mean, research is almost never objective. Let's just forget about that notion, right? So when I went into it, I thought it would be structural things like, the nurse swearing at me at the clinic, or one of the things that is starting to emerge for me is this relationship of, like, if I'm in a romantic relationship, at what point do I disclose my HIV status? And where do I store my HIV drugs so that my partner with whom I live does not see my HIV drugs? Because that would then, like, forcibly disclose my HIV status. And so, that's starting to surface very strongly as a theme across what I'm seeing, in the different transcripts. So, yeah, I mean, my advice to you, like, if you work in that setting, look at the LGBT HIV plan. It speaks very much of integrative care. And, this has been the argument that we really pushed, like, even if you say you can't give us surgery, like, you should make hormones available, and these are the reasons why you should make them available. And one of those reasons being that if you offer them alongside each other, you have a better chance of retaining me in ongoing care, insofar as HIV is concerned.
Thanks so much for that very comprehensive response. I'm just wanting to check if Anastasia is back with us and if you have anything you'd like to add to that.
Yeah, hi. So I have stepped back in for a minute. Unfortunately, I wasn't able to follow all of what Leanne was saying. But if there are other points for discussion, I'd be happy to speak to them. I can say that what I did catch of Leanne's presentation and comments, I do strongly agree with.
I see I've got another hand up. Is that Harpe?
Yes, that's Anil. So from my end, it's a bit of a comment. Perhaps we'll end up having a question at the end, because we are speaking around amplifying voices within the Southern African region. Hey? So when you look at the ASA context, particularly when you speak about HIV and AIDS and structures being in place, when you look at the already expired HIV strategy plan, I like the fact that Leanne highlighted an area to say that there was an excitement at some particular point at the beginning without us fully understanding what does it mean. So now, me being in the region, I want to move beyond ASA. I want to move within that being identified. You would find that in the region that's the quite opposite. If you look at all the strat plans in the region, they're saying nothing about the trans community. They're saying nothing about trans. There's nothing about diverse identities. So in that particular point, already on its own, in terms of instructions are put in place in terms of possible for you to access, whether it's based on the issue around stigma or discrimination. Now it's another conversation on another level. But then in the regional stage, it starts off with, am I recognized? That's where the key question becomes. So on top of that, you'd find that even also the words that key population. In key populations in ASA, we have a very rich context of understanding what it means, who it's including. The very same concept, it's becoming a problem for the trans persons. It's becoming a problem in a sense that states are hiding behind the word key populations. They're hiding because the fact that laws do not recognize trans. Now it becomes difficult in terms of, if you do not recognize, how else am I going to say that I'm going to be providing services towards you, or towards how am I going to be living up to that obligation that I have set up at the African level and also the AU level, to that one of my biggest obligations to see that everybody enjoys the right to life and stay for security. But then in actual fact, when key population, you're going to realize that when you get into other states except for ASA, when you refer to key population, it becomes a problem to say that, are we seriously having trans and gender that's in country? And you find that that is not the case. It becomes difficult even also to act medication, clinical services like anesthesia was already pointing out. It becomes a problem on its own on that stage to say that if I'm expected to present my ID and then my ID does not resonate with my physical appearance, it becomes a problem even just to access ARVs. So now let's look at it in the context of COVID-19. When you look at COVID-19, there are some of the threats that also have been with HIV and AIDS. Most of Southern African countries are worried about accessibility to ARVs. Now it comes to what more for the trans community? Or figured under what is specific to be normal circumstances to access. Now it becomes even much more straining if COVID-19 is already threatening accessibility by those who are said to be from the normative society. What more about the trans community, the threat? So I'm thinking our conversation, we also look at them in terms of how do we try our level best, looking at some of the issues beyond the context of ASA and learning also, of course, we can always learn from ASA, but how do we move beyond that? How do we bring these conversations that we find that the white key populations is stop becoming a problem for us? So I think that's just a bit of my input here.
Thank you, Harpia, for bringing in the Southern African experience. If maybe Leanne and Anastasia will have anything to say in response to that, that would be very useful.
Sure, I'll jump in because I'm probably going to have to run again in a minute. But I agree with the sentiment entirely. I think one of the big issues is that the concept of key populations has been employed in order to divest the systems and the infrastructure that we work in the society and the government from responsibility towards human rights. And, I think the big problem is that this says we understand and recognize you only in a sense of this one limited facet of your experience. And that's why we're prepared to take action on this. We're prepared to take action through the HIV lens, but we're not prepared to acknowledge and uphold your human rights. And this is this is definitely a tremendous problem. And, you know, I think the tension that we all struggle with is how do we balance this human rights movement with the possible peril of losing access to what little kind of service we have. But certainly it's a case of us needing to stand up and say, you know, we're not prepared to accept second-rate treatment. We're not prepared to accept a scrap of dignity. We really are at a point now in the development of our understanding of gender and sexuality and diversity, where everyone should be accorded human rights, and it shouldn't be up for debate. It shouldn't be that you get a fraction of the rights that everyone else has just because you're seen as a vulnerable population for HIV infection. And at the same time, we can't wave that flag of key populations and the work that we're doing to say that we're doing enough in order to look after the healthcare and the general needs of trans and diverse populations. It's not enough. It's not an excuse. We always have to do better. So I think the responsibility there is definitely twofold. We as a community need to seek new ways to make our voices heard and to get people to understand that our experiences are so much more broad than just this narrow reductive lens would suggest. And then I think it also comes down to how do we involve people who are in positions of authority, people who are making decisions, people who are rolling out these programs and designing these programs. How do we find allies in that community space and get them to mobilize and to help amplify those voices from our own community? So I think those are all very valid points that have been raised, and I definitely agree. I think too often this key population concept is really just used as an excuse or as a way for us to pretend that we're taking action. We are taking action, but it's not enough.
Thanks so much for that. I do acknowledge we've got a hand up from Tsitsi, and we'll take you in a minute. I just wanted to hear if Leanne has got anything to say to the last question before we go to Tsitsi's question.
Yeah, I think, I mean, you know, it's kind of a complicated one, but, you know, the thing that makes me hopeful, happy, is that I said, you know, it's important to acknowledge that years and years we were as part of the MSM group. We, you know, are recognized as key populations within our own right, without kind of finding like what is key population and who defines right. But in later years, when we started producing evidence to see we could go back to that MSM and extract samples of transgender people from there, build arguments on that. And yes, it's been a long shot. It's been a very great one. The one thing that, you know, one tactic that I've been using is when I talk to policymakers, for example, it's been an incredibly difficult one. People will cite them Europe and America that is outside of our context. I have cite data from Argentina and India because those are all global south settings, right? You know, we haven't always had data. We just recently got HIV data, and we have a long and also speak to, you know, I think go out and see, you know, seek who will listen to you within SEDEC, within COMESA, look at those structures. And, you know, there are people who will listen to you. Not everyone will, because not everyone will buy into your agenda. But I think it's a purpose, like seek those people. Nothing being so, for example, for like when I speak at in Geneva at the Human Rights Council, I make time to go and see the South African mission there for them, you know, to talk about what is that's going on in Africa, what's happening around trans health. So you've got to like very strategically seek out allies to push forward the agenda.
Thanks so much. We are now going to go to the question or comment from Tsitsi.
Thank you, Leila. Thank you to everyone for hosting this very important conversation. I am Tsitsi Maradze from Zimbabwe. I am a human rights defender, and I have a passion, very strong passion around gender and inclusion. And therefore, I'm working quite closely with the LGBTI community in Zimbabwe as well as in the region. Comment, and I'm sorry, I will need to be leaving immediately after this because I have another meeting in 5 minutes. So my comment, just to reinforce what I'm hearing from the doctor, from Stacey, and from all the other colleagues, including Leila, I just wanted to share an observation and maybe pose a question that I would like to leave, which is really around capacity. So for me, I increasingly encounter issues of capacity strengthening, and I think it's really like the key, perhaps one of the key strategies that we really need to ingrain in the whole discourse, including in our programming, to make sure that trans people can also equally access healthcare, even in the context of HIV. And for me, the biggest threat that I continue to see is around stigma, which can be self-stigma or it can be stigma, including from the KP community itself, the stigma around trans people, as well as the stigma from the general population. And now with COVID, I can confirm in my own country that it's just a nightmare, it's a mess. Stigma is pervading all aspects of human interaction, to the extent that we actually have people even running away from quarantine centers the moment someone is labeled a COVID positive person, including even in the communities that they are running to because of that labeling. So I'm just wondering what creative and other innovative strategies can we actually employ to strengthen the capacity, especially of the trans community, so that at least they can be more included in our strategic plans, national strategies, like someone highlighted. It's a real, I think, gap. And the KP community, for example, generally does not even get a seat on the table where some of these key decisions are made. And therefore, what kind of allies from a lobby and advocacy perspective can we draw on to make sure that that voice can still be heard, even if they're not physically present in that space, again, because of stigma and all these other human rights barriers. So for me, I'm interested to continue this conversation and I'm interested to continue to participate, but it's unfortunate that I have to leave for another meeting. But thank you so much, Leila. Thank you, everybody, for this opportunity.
Thank you so much, Tsitsi. You've raised some very, very important points. I think given the amount of discussion that we're having and the time that is going very fast, possibly this is an issue that we need to flag to have a deeper conversation at some point later on in our program. So possibly we could look at that and include you in it. But thank you so much for being here and for making those comments. I just want to go back to our panel and see if anyone has anything to say in response to the points that Tsitsi raised.
So Titi asked about who should be our strategic allies from the perspective of lobbying and advocacy, right? Hello?
Yes, you broke up a little bit, but we can still hear you.
Okay. So, I mean, you know, the thing that I always say is that, you know, the way to hell is paved with good intentions. And sometimes that's why, you know, we think we need a community. And so I would say to see that, and, you know, in context of lobby and advocacy, that has to be determined by the community at hand, which is the transgender people. They know best what is the agenda that they drive within country in Zimbabwe, and that can only be enforced in Zimbabwe. We can maybe propose as South Africans that, you know, we should speak to SADC, or we should speak to other regional bodies, but in doing so, we might cause more harm than. So I think to answer this, the reflection should from transgender and performing folk within Zimbabwe.
Thanks, Leanne. I think we've lost you again there, but we did hear I think most of your point on that. Do I have any other questions or comments before we close for today? I did see Grayson's hand up earlier. I'm not sure if you covered, Grayson, or if there's something you'd like to raise.
No, thanks, Anila. I'm covered. Thank you so much.
Thanks a lot. Is there anyone else who has anything else that they would like to say? Okay, I'm going to take silence to mean that we've covered our questions and answers for this session. I think it's raised a lot of questions, and possibly this is something we need to look in deeper into in future conversations. But I'd really like to thank Dr. Anastasia and Leanne for giving us their time today and giving us some really thought-provoking issues to think about. I'm going to now hand over to Harpe to do the close and to say thank you.
Thank you, Anil, and everybody was able to join. Thank you so much. This has been quite an insightful conversation, which I feel, and I think most of us probably were left with that sense of saying that, have we done enough with actually unpacking this? And I would say from where I'm standing, we have unpacked to the level of SA and a bit of the region. So perhaps it's something that we should consider amongst ourselves, she, Iranti, gender dynamics, and all the other on board, and looking at how are we going to integrate care within the regional level. How are we going to go forward in put in mind areas around legal recognition of transgender and gender diverse persons, and then also putting in mind the involved trying to provide the necessary support, which is the key thing, us being able to support each other, avoiding to work in silos. And that, for where I'm saying, would mean that then there's somewhere where we're intending to go, there's somewhere we're intending to just actually support each other beyond these conversations, because fortunately these conversations, they seem to be unpacking a lot of things that help us to say that these are the intervention strategies that are required within our movement. So that being said, thank you to make that time to join us today. And may I add, let's try as much as possible to avoid getting infected with COVID-19. Those who have, we will definitely wish them for a speedy recovery. By the end of the day, it's affecting all of us, indirectly or directly. So much as possible, and also to make life a bit easier for us to see how best can we fight, not forgetting our positionality, not forgetting how we perceive our own understanding, that we need to make the rest of the world to understand. It is within us, and that's something that I'm pretty sure that we all have the potential and the capacity to be able to do. That being said, everyone, and enjoy the rest of the day and the week ahead.
Thank you so much, Harpe, and thank you so much for everyone who's joined us here today. We're going to be sending out notifications. We're going to be meeting again in 2 weeks' time, and we've got another program of issues for our community that we're going to be addressing, and Leila is going to be sending out information on that in due course. But I'd like to just also say that the person who's behind the scenes in all of this, who really brings us all together here, is Leila, and I'd just like to acknowledge and thank her for all her hard work that she does on bringing these conversations together and making them all go smoothly. Thank you so much, Leila, and thank you everyone for joining us. Goodbye.
Thank you. Goodbye.